Hello, everyone. Welcome to Asia Novel Seminar, which is hosted every month by Asia. In each episode, well-known experts will be invited to discuss treating topics in arthroplasty. We hope to establish professional forum that joint surgeons all over the world can be connected to share their ideas, clinical experiences, and cutting-edge techniques in order to solve clinical problems and improve the development of arthroplasty in Asia. This is the fifth session of this program. I'm He Chuan from Shanghai Jiao Tong University School of Medicine, Region Hospital. I will be the moderator of this seminar. Topic of today is unstable TKA. It's our honor to have three distinguished guests with us today. Even I'm sure every surgeon in China has known them very well, but I think it's better let's do a safe introduction first. Michael?
Thank you, Professor. I am privileged and honored to be able to participate in this program today. My name is Michael Hu. I'm an orthopedic surgeon in Dallas, Texas, in the United States. I work at the University of Texas Southwestern Medical Center. Thank you.
Professor Zhou, your turn.
Thank you. It's my honor to be invited in this webinar on the topic of the unstable total knee arthroplasty. And I'm an orthopedic surgeon from General Hospital of Chinese PLA, People's Liberation Army. I'm very glad to meet the old friend Michael, Charlie, and He. Thank you.
Thank you. Charlie?
Thank you, Professor He. Hi, Michael. Hi, Professor Zhou. Welcome everyone tonight in the audience. It is an honor to be invited by Professor He Chuan to be part of this WebEx on unstable total knees. It's also a pleasure to see my old friends, Professor Zhou in Beijing and Professor Michael He in Dallas. I think one of the beautiful things about COVID, there's something positive out of COVID, is that we get to see each other on the internet now, and yet continue to provide education for the attendees out around the world. So it's an honor. Thank you.
Thank you all. Let's start seminar. I will share my screen. As we know, TKA is very successful surgical procedure in patients with non-stage knee disorders, especially in degeneration, arthritis. We know the number of TKAs performed annually continuously increased, especially in China due to the huge population and the aging society. But according to the literature, the instability is a common dissatisfactory factor and the common indication for early revision after both primary and revision. We can see the number from this table. We can see that instability accounts for 2.5 to 27% of the revision, total revision. So it's not uncommon course in our revision case. This is a classic case in my practice. The female received a left TKA 8 months before. It's 63 years old. But she felt persistent pain around the knee and recurrent infusions after TKA. Always limping and cannot climb stairs. and the symptoms was last 8 months and get worse. The patient come to our hospital. From the X-ray, we cannot find an observe abnormal, but patients feel bad. So always can find that for them, the patients feel bad, but X-ray looks good. But we can see his gait is very painful. I did a revision for her. In the revision surgery, I found the global instability in her knee, and the extension space is bigger than a flexion space. So I revision her with a CCK and using the distal femoral arguments and the proximal tibial arguments to balance the spaces. Just 1 month after revision TKA, patient can walk without pain. So feel better, much better than before. The problems we face is sometimes the unstable TKA is difficult to diagnose and treat. A second is how to prevent this problem, how to prevent the instability in primary TKA, primary and the vision TKA. I think the 3 guys will share us their experience and knowledge. Next, it's maybe Professor Charlie Yang will share us how to diagnosis and assessment and unstable TKA.
Great, thank you so much. Yep, if you can unshare your screen, and then I will share my screen.
Okay.
The talk. Great, thank you so much. Let me share screen. Thank you again, everyone, for the opportunity to present on this topic. I've been assigned the topic of unstable total knee arthroplasty with evaluation and diagnosis. Again, I want to thank the Asia organization for the opportunity to be part of this WebEx. Again, I want to thank our moderator, Professor He Chuan from the Shanghai Ruijin Hospital for his invitation to be part of this WebEx. Again, I want to I'm really happy to see Professor Zhou Yongkang from the PLA 301 Hospital in Beijing. And again, it's always nice to see Michael from UT Southwestern here in Dallas, Texas. As far as a little bit about my background, most of you probably don't know where Denver, Colorado is, so this is actually a US map. As you can see on the West Coast, on the left side there is California. Most people are certainly familiar with California. And on the East Coast is where New York State is. And I think most people are familiar with New York State. And I actually just added Texas in there just to represent where Michael is from. So actually Denver, Colorado is a little bit farther away from Texas than you think. NC, North Carolina on the East Coast, it'll become relevant shortly because that's actually where I grew up in the United States. So a little bit of background about myself. I am part of Colorado Joint Replacement, which is part of Porter Adventist Hospital located in Denver, Colorado. We're actually a very small hospital, only 368 beds facility, and we're actually hospital employed physicians. We started this model back in October 2014. As part of our group, we are a total joint replacement practice, focusing on mainly total knee arthroplasty and total hip arthroplasty. Our group consists of 5 partners: Dr. Douglas Dennis, Dr. Tom Miner, myself, Dr. Jason Jennings, and Dr. Lindsay Kleeman, who's actually the newest member of our group. She was actually our fellow last year, so she's very new to our group. Our clinical volume, we do about 2,000, just over 2,000 cases per year, of which 85% consists of primary total knee arthroplasty and 15% consists of primary revision total joint arthroplasty. We currently offer a fellowship program, which is 1 year in duration, and we currently accept 2 United States fellows per year. We're actually on number 29 now. And these are actually the 5 of us in the group. The person in the middle is Dr. Douglas Dennis, who actually is he's a world-renowned total knee arthroplasty surgeon, and his claim to fame is all the kinematic studies in total knee arthroplasty. And to the right is Tom Miner, to the very left is Jason Jennings, and Lindsay Kleeman is to the very right. So just a little background about myself. I completed my orthopedic residency in 2006. In the United States, our orthopedic training consists of 5 years after our medical school. After my orthopedic residency, I was fortunate enough to come out to Colorado joint replacement in Denver and spend a year with Dr. Douglas Dennis and Brian Haas, who are my two senior mentors at the time. After I completed my fellowship, I actually went back to North Carolina and joined a multi-specialty private group from 2007 to 2011. In 2012, I had the opportunity to come back to Denver, Colorado and join Colorado joint replacement, partly because Dr. Haas at that point was thinking about retiring. So I've been here to Colorado joint replacement for the past 8 years. My focus in my practice consists mainly of total knee arthroplasty and total hip arthroplasty, of which the breakdown is about 50% hips and 50% knees now. So as we talk about instability of the total knee, as Professor He Chuan pointed to earlier with his slide, the incidence is variable between 2 to 22% after total knee arthroplasty. Patient may just feel like the knee feels loose, or in severe cases, the patient is afraid to put weight on the unstable knee. More often than not, the patient does not trust the knee after the replacement. Instability of the total knee can be due to multi-factors, including number 1, ligament laxity, number 2, chronic stretching, number 3, trauma or implant malposition, or bone loss, or technical errors such as in surgical dissection. If uncorrected, the major knee joint instability will lead to excessive stress on the components, and this will eventually cause prosthetic loosening and destruction of the entire total knee prosthesis. As you can see by this exam here, under anesthesia, the knee is quite unstable under manipulation under anesthesia. So TKA stability can be stabilized with component articular geometry, as in the design of the prosthesis. And it can also be affected by soft tissue support, such as the ligaments, the capsule, as well as the muscles around the native knee. There's advantages and disadvantages with total knee arthroplasty constraints. The advantage with more constraint is that it leads to less instability, but the potential disadvantage is that it increases fixation stresses in the implant, which could potentially lead to premature aseptic loosening. The stability is better obtained. Question is whether it's better obtained biologically versus with the prosthesis. So just to touch on the classification of total knee instability, we have medial and lateral, which is in the coronal plane. We have anterior and posterior, which is in the sagittal plane. And we have global instability, as shown by Professor He Chuan in his example, with a mismatch in flexion and extension. The instability can also be classified as symmetric versus asymmetric. Some of the etiology of total knee instability includes ligament imbalance, malalignment of the lower extremity, component malpositioning, component failure, or the faulty prosthetic design, such as a flat design of the prosthesis. Certainly, newer generation design have overcome some of the initial design flaws of older prosthesis. What are some of the clinical history taking of a patient presenting with an unstable total knee? More commonly, you will hear a patient complain of pain. You will hear patients say that the knee has never felt right. And the patient will always complain of swelling associated with activity. And more often than not, the swelling is actually relieved after rest. More often than not, you will hear patients complain of difficulty with stair climbing, especially with descending or walking down the stairs. Patient will also complain of weakness, and sometimes patient will complain that the knee makes excessive noise in the knee. And patient will also state that the knee occasionally will give out. They don't trust it. So how do you make the diagnosis of total knee arthroplasty instability? Number one, this is done with a clinical examination. And this consists of measurable ligamentous laxity. Patient may present with hyperextension of the knee, or on exam, patient may have a posterior sag sign and a swelling of the knee, which is consistent with an effusion. Radiographically, we have to get weight-bearing x-rays to look at a low-bearing joint. And this also can be done with a dynamic fluoroscopic exam of the knee. Collateral ligament instability may be a result of trauma, attrition, bone loss due to osteolysis, or difficult dissection in a stiff knee or a morbidly obese patient. Posterior instability may be a result of ligamentous attrition or technical error when implant instrumentation is anteriorly referenced and too small of a femoral component is implanted. Therefore, the flexion space is increased. Posterior instability with a too small of an implant, as shown here, can lead to varus valgus instability in mid-flexion, as well as knee pain when descending down the stairs or down an incline, because the knee will give out. And usually on the x-ray may be very normal with excellent range of motion, as shown here on the x-ray example on the right. So on a normal exam, the knee will have approximately 2 to 4 millimeter of play with stress. As you can see, this patient here with walking, the patient has a tendency to hyperextend a little bit, and she has an antalgic gait. And on the exam on the bottom left, we examine the table on the operating on the clinical room in the exam room, and you can see in mid flexion and 30 degrees of flexion there is some laxity in the knee. Patient may present with hyperextension as well as a posterior sag sign and swelling of the knee. On physical exam, like I alluded to earlier, there is swelling. Patient will guard, which means they are apprehensive when you examine the knee. To test for instability, laxity of the knee, you want to make sure the knee is flexed both at 30 degrees as well as at 90 degrees. The collateral insufficiency may be mass in full extension due to a tight and solid posterior capital. Here's an example of medial laxity with valgus stress under anesthesia. So as we stress force laterally in the joint line, you can see the medial joint space certainly opens up on this example. Here is a sag sign with the A to P 90 degrees. We have the knee shucks medial in the A to P direction. And here again is the medial lateral exam, and there is instability along the medial aspect of the joint line. Again, as we arc through the range of motion here, testing flexion instability, you can see the knee sags back. It rolls back and just drops down in flexion. So on radiographs, these x-rays, these knees may often be normal. However, if there is instability, sometimes you can see a subtle static sign in flexion extension with the tibia rolling backwards. And this can lead to gap imbalance in the joint space. As an example shown here, this is a post-op valgus deformity preoperatively. Post-operatively, you can see the joint space open up a little bit medially. The middle picture is the supine radiograph. And when we ask the patient to stand, you can see that the forces even goes down to the lateral joint space and actually opens up the medial joint space even more. This is an example of a very subtle posterior sag sign. In flexion, the tibia has a tendency to slide posteriorly, as demonstrated here. So the weight-bearing X-ray can also have asymmetry with the laxity of the, which shows the laxity of the collateral ligament, as shown here. The right knee itself, in a standing X-ray, you can see subluxation of the femur medially across the tibia. You can also see if the component, there's a under recession of the distal femur. You can see that the distal placement of the femoral component can also lead to instability of a total knee. As shown in this example, when you anterior reference the femur, sometimes you can remove excessive posterior femoral bone, and you can actually put a smaller femoral component in there, and this could lead to instability in the flexion space. Here's an example of a extension instability, which is symmetric. And this is usually secondary to excessive bone resection or bone loss, as shown by this patient. And there's also, it may also lead to secondary to the soft tissue laxity, both of either the medial collateral ligament, the lateral collateral ligament, or the posterior cruciate ligament. And this could result in a varus valgus instability, both in 30 degrees of flexion as well as in 90 degrees of flexion. And the patient may walk with a recurvatum of the knee, meaning hyperextension of the knee. This is an example of recurvatum in extension instability. We most commonly can see this in neuromuscular disease, and as well as rheumatoid, with polio or patient with hydrocephalus. There's substantial quad weakness, and this will cause hyperextension of the knee. When you see this clinical scenario, be very cautious, be very aware that this could lead to early failure of the total knee arthroplasty. This is an example showing improper component positioning in inaccurate bony resection. As you can see, the primary procedure done on the left, the tibia is cut in slightly varus, and we had to restore the normal alignment and restore the joint line with the revision total knee arthroplasty. This is an example of a flexion instability, which is symmetric. You can see the femoral component is too small. This is undersizing the femoral component, and that the tibial component can also have too much tibial slope. And this can certainly lead to a posterior sag sign and subluxation of the tibia posteriorly. Flexion instability in the asymmetric setting. This is typically due to error in the femoral component rotation. This is typically caused by too excessive internal rotation of the femoral component. As we all know, proper placement of the femoral component can be achieved with parallel to the transepicondylar axis or perpendicular to the AP axis, such as the white-sized line, or approximately 3 to 4 degrees of external rotation relative to the posterior condylar axis. Or another method to do so is parallel to the tibial cut, such as a true flexion gap balancing technique. This is an example showing flexion instability in the asymmetric setting. The collateral ligaments, as shown here, are imbalanced. And because this is a cruciate retaining construct, the tight PCL can lead to a tight posterior medial gap or a loose posterior lateral space. And this can result in femoral condylar liftoff if you actually fluoroscopically examine this patient, because the error is that the femoral component rotation is internally rotated. So, in summary, total knee instability, there are various types, and I think our next presenters will certainly go into further details on the classifications and the treatments of these. The key with every total knee arthroplasty is to make sure we must restore the flexion and the extension gap space and make sure they are equally tensioned and equally spaced. There may be the question is whether the total knee instability is better managed biologically or with prosthetic design with increased constraint. So in summary, with total knee instability, number one, how do we diagnose it? Is to take a careful clinical history. The patients will more often than not say, my knee gives out. I have difficulty with descending stairs. I don't trust my knee. On physical exam, you want to look for laxity of the knee in 30 degrees of flexion as well as 90 degrees of flexion. And you want to test for the AP stability with the post AP drawer test. Radiographically, make sure you get weight-bearing views because that will accentuate the joint space if there is instability present. And you want to make sure there's proper alignment of the lower extremity with accurate bony recession and appropriate sizing of the components. So I hope everyone, when we're safe to travel again, I want to welcome my Chinese friends and my Chinese colleagues to Colorado Joint Replacement at Porter Adventist Hospital. This is certainly, obviously, pre-COVID. We certainly had the wonderful opportunity to host some of our Chinese colleagues at our institution. And if you ever get a chance to explore Colorado, it's actually not a bad place to visit. We have a wonderful outdoor scenery here in the Rocky Mountain region. So with that, thank you very much. I'll give it back to you, Professor He Chuan.
Thank you. It's a very excellent presentation. And your example is so impressive. I think it's
well, here's the thing. We always have bad ones. we don't always have perfect ones.
That's very educational. I think I have a question. Do you think the aspiration of knee have some help to diagnosis for unstable TKA?
That is an excellent question. I think every painful total knee or any unstable total knee, first and foremost, is to rule out infection. That is an excellent point, Professor He, because you actually asked a very astute question because the treatment for an infected total knee is very different than an unstable total knee. So you're absolutely correct. So the algorithm of diagnosis is number one, if the patient have a painful or unstable total knee, is to rule out infection. You're absolutely correct.
Yes. Professors, do you have any questions?
They're being too nice. They're my senior friends. They're being too nice.
No. It's very good. It's very good. Your presentation very good. So we can understand how to diagnose unstable TKA. Well, I think I get a lot of you.
Yeah, because I truly think one of the most important things, we teach our fellows, we teach our residents, we even teach our medical students. One of the most important things, not just orthopedics, I think in medicine, right? Even every subspecialty, family medicine, internal medicine, is a good clinical history taking, asking the patient and listening to the patient, because patients will express what they're unhappy with or even sometimes they're happy with. So a clinical history taken is imperative for the diagnosis of an unstable total knee.
Okay, Charlie.
I have a question for Charlie.
Yeah.
You just mentioned that you talked about the mid-flexion instability. Do you think it really exists, the mid-flexion instability, and how to prevent during the index surgery?
Yeah, that is an excellent question. See, when people with lots of experience, they ask very smart questions. So I truly think mid-flexion instability, it is a phenomenon. I do think if you have an unbalanced knee, patients, you can present with mid-flexion instability. Now, as we all know, we don't balance the knee technically at the initial index of surgery in mid-flexion. We balance the knee in full extension and in 90 degrees of flexion, right? So we don't balance the knee in 30 degrees. So to Professor Zhou's question, how do you avoid mid-flexion instability in the initial index of surgery? The key is to make sure you have a good selection of your prosthesis, because the implant design is what is going to overcome the phenomenon of mid-flexion instability. You want to make sure you have a round on round type design. You want to make sure potentially you have a posterior stabilized design, increased constraint from cruciate retaining to anterior stabilized, which I think Michael will present in his talk, to a posterior stabilized, to a semi-PS plus, to a more constrained TC3, CCK, or to a linked prosthesis. So that is the spectrum of how you address using constraint, meaning the design of the prosthesis to address mid-flexion instability. So implant design, we can't do it technically. We gotta pick the right implants.
So you mentioned that surgeons always test the stability at full extension and flexion at 90 degrees. But if you use gap balancing, you just do the two things and do not test at the other flexion degree.
Yes. Yeah. So to me, that's why I think it's so important, Professor Zhou, to make sure there is enough congruity with the femoral component radius of curvature, and the conformity along the articulating surface of the polyethylene, because they have to make sure that conformity is high enough or sufficient enough that it will hopefully address or eliminate the problem of mid-flexion instability. You're absolutely correct. Implant design.
So implant, you mean that a single radius of the posterior condylar design is have an advantage?
No, I think it's just a different philosophy. I think there is just a matter of philosophy. Obviously, there's two schools. There is a single radius, which Dr. Zhou pointed out, and there is also a multi-radius design.
Yeah.
So I think it's based on depends on, for me, I think single radius works very well in a cruciate retaining or a anterior stabilized construct. I think a multi-radius design can work in cruciate retaining, anterior stabilized, or a posterior stabilized design. So I think the key, as you pointed out, Dr. Professor Zhou, is to make sure you have use a technique that is reproducible and that you balance the knee.
Professor Zhou, Dr. Michael Hu will talk about the prosthesis design in detail later. Okay. Charlie, I have a question. We know sometimes we will have some patients with weak muscle strength. How do you know this loose in your physical examination is physically or pathologically?
Yeah, that is an excellent question. When we teach our fellows, because on physical exam, the amount of laxity with varus valgus and A to P, that is very subjective, because our current fellow is very strong.
Yes.
He has a lot, he can make the knee very loose, right? Versus me, if I'm gentle, right? Or, whatever amount of stress I put on the knee, that may be very different than the next person examining the knee. So just because a knee may feel loose to me, it may feel very different to Michael. It may very feel different to Professor Zhou, or it may very feel different to you. So what I think, the sequence is, number one, listen to the patient. So in that part, clinical history taking is so important. When I feel the knee is loose, I always ask the patient, do you trust it? Because if the patient goes, oh, it feels fine, I feel great, then I don't even worry about it, because I can always make it worse with a revision, right? Because if the patient like it, it may feel loose, but it's okay, right? So listen to the patient. So as far as laxity on exam, I correlate that with the history taking. If the patient is very loose on exam and the patient goes, oh, I don't trust it, it gives out, then you put the two together, then I think consistently that to me sounds like a unstable total knee. So history taken, very important.
Yeah, very useful. Okay, let's go to the next section. The next one is presented by Professor Zhou Yonggang about the classification and the treatment of the unstable TKA.
Okay, thank you. It's my honor to be invited to join this webinar. And my topic is instability after total knee arthroplasty, classification and treatment. And just as Professor He said, that total knee arthroplasty is a very successful surgery. Although that there are some cases that are needed revised, and the instability among the third. The second main cause of the failure of the total knee arthroplasty. And Charlie have talked about the etiology of the instability and failure to correct the previous deformity and overcorrect the previous deformity. And sometimes the technical area can cause the instability. The technical area include unable balancing the extension and the flexion gap, misalignment of the components, bone defect, loosening of the implant, polyethylene wear, and periprosthetic fractures. And there are some classifications, and there one classification according to the time of the instability happens. One is early instability. Most time is because of technical area, and the late instability is because of loosening of the implant, bone defect, polyethylene wear, and the failure of the implant, such as that this collapse of the tibia plateau, medial tibia plateau, and the failure of the tibia plant, and the premature wear of the polyethylene. And most accepted classification is like this. Charlie already mentioned that extension instability is include symmetrical or asymmetrical. This type is more common. And another is flexion instability. That means that the flexion gap exceeds the extension gap. And sometimes in CRNE, PCL insufficiency, it can cause flexion instability. And then another type is global instability. It means that both extension and the flexion instability, even with the extensor mechanism disruption. But this problem is not included today's discussion. And then another type of is requatum. Dr. Charlie already mentioned that, and also mid-flexion instability. There are many treatment options, such as isolated polyethylene exchange, single component revision, full component revision, and sometimes more constrained components are needed. Isolated ligament reconstruction will not be successful in the setting of the total knee arthroplasty because different kinematic of the total knee arthroplasty with navy knee, and polyethylene exchange to thicker insert is generally not adequate for isolated flexion instability or extension instability because it can fill the larger gaps and will tighten the other opposite gaps. And treatment for extension instability is that in symmetric extension instability, usually because of failure to fill the extension gap. And sometimes the distal femur augments are commonly used to lower the joint line and tighten the extension gap. Here example, this patient had a left total knee revision because of recurvatum half a year after index operation. This is just after index operation, and this after revision. And the recurvatum appear half a year after the revision. And the examination shows that instability in extension, and after revision, he got a stable knee. And symmetric extension instability also usually increase the. It's already said that increase the thickness of tibia polyethylene will fill, as it will tighten the flexion gap. But in rare cases, just in these cases, it can help. This patient have a recurvatum 1 year after operation. As you see that although the tibia is placed at various position, but besides that, the alignment is acceptable. But because the space of the flexion gap is low, it's very narrow, so the surgeon use a sinker polyethylene insert to match with the flexion gap, but the extension gap is much larger than the flexion gap because recurvatum, and cause post impingement. So for this patient, I just use a thicker polyethylene insert, and so he got a stable knee. For the reason is that this is a PS knee, but the surgeon left the part of the PCL and caused the tighten of the flexion gap. So polyethylene exchange only, there's a report of successful rate of the 71%, but most other results not so good. But extension instability also include asymmetric extension instability. It can happen at the early stage, or also can happen at the late stage. For the early asymmetric extension instability, the reason is the failure to correct the alignment in the coronal plane, or release the soft tissue on the concave side. This is unable to correct the valgus knee, and this case is over release the MCL and cause the extension instability, and just revise the tibia component, left the femur component. And also this patient is earlier asymmetrical extension instability. It's valgus knee have done by other surgeons, and but the patient after surgery, the patient did not trust his knee because some problem with the RCL. So I do the revision for him. Use a constrained knee, and the patient got a stable knee. Can also squatting. Single component revision is the left retained component must be stable fixation and have a proper axial alignment. But the full component revision are more successful than partial revision. And for the treatment of extension instability happened in later stage, it's mostly because of ligament attenuation, component loosening, polyethylene insert premature wear, and sometimes the failure of the implant. This is collapse of the tibia plateau, loosening of the tibia component, and premature wear of the tibia insert, and sometimes the failure of the tibia component. Here is a revision for the collapse of the medial tibia plateau, also loosening of the tibia component. I will revise with this cone. I designed this cone, and it's very stable. And use a constraint knee. And another patient also have loosening of tibia component and the collapse of the medial tibia plateau. And the patient also has some sign of recurvatum. And I use a sleeve reconstruct the bone defect. This semantic just looks good, but no, I don't think it's used for the stable of the component. And the 3 years after operation, the patient is very happy with his knee. And another case is loosening of the femur component, also cause instability. And there are no left condyle left. So I use many schools also use sleeve to construct the distal of the femur. And another case is you use sleeve and augments to reconstruct the left medial condyle bone defect. Because of the patella baja, I use TTO to expose the knee. Another example is instability of the right knee because of premature wear of the polyethylene insert. And the reason is that the surgeon didn't rely the lamp very well because left various alignment. So I use a soft cement stamp, lateralize that and correct the alignment. And another example is maybe like a global instability, also cause a breakage of the post. Here's the after operation, after revision. And another most severe cases, and this IP2 component, and 10 years after total knee arthroplasty, and got loosening both of the component, femur component and tibia component, and also have malunion of the supracondyle fracture. So I realized that with a cone and 2 tibia augment with 10 millimeter thick, also use 21 thickness of the polyethylene insert to restore the joint line. And 7 years after the revision. And another case is the failure of the hinge knee. This is from Vitamin Link, Germany, because the design is that the have a polyethylene liner in the femur component of the socket. So the wear of the polyethylene causes unstable of the component. So I revised that and use another hinge knee, rotating hinge knee. Another design much better than the first one. So the patient 5 years after revision. So now come to the flexion instability also can occur at the early stage, also at a later stage. But early stage can happen as a PS knee, also can happen with CR knee. And for the acute instability, Lombardi said that can can be treated successfully with close reduction and bracing. This is my patient and bilateral valgus knee, and I did the simultaneously did the bilateral total knee arthroplasty, but 3 days after operation, the right knee dislocated. This is my only one dislocated patient, and I close reduction, treated with close reduction and brace for 6 weeks, and 3 years after operation. The bilateral knee are stable, and the patient can also squat. So the acute instability can be treated successfully with close reduction. And for the late flexion instability, the cause including femur component too small, excessive tibial load, or PCL incompetence in CR knee. Treatment including that treatment can include that upside the femur component with augment, reducing tibial slope, sometimes use additional constraint. Here's CR knee. The patient 7 years after operation, but the patient have a recurrent joint effusion 4 years after operation. And this CR knee also has got some like a global instability. So insufficiency of the PCL for the CR knee. So I did the revision and gave the patient a stable knee. Another patient, this patient, just like Charlie said, didn't trust his knee. So with came. So I did the revision. To correct the mismatch of the extension and the flexion gap, and the patient gave a stable knee and also can squat. Global instability, is a stability in both flexion and extension caused by ligament incompetence or rupture. Large flexion and extension gap mismatch often require hinge knee revision. Here example, the other surgeon did the two-stage revision for the infected total knee arthroplasty, but the patients got several times dislocated using the spacer. So I did the revision with a hinge knee because there's a rupture of the MCL. And this another case is a CR knee. The patient have a CR knee, but 1 year after that, come to me with this PCL competence and extension instability. During the operation is that for the extension, I can use 17 block, but for the flexion gap, this is 20 millimeters block, but much larger than 20. So I cannot balance the extension and the flexion gap. So I use a hinge the link from the vitamin link. But 4 years later, the patient again get an unstable knee. So also because of the wear of the polyethylene liner in the femoral socket. So what's the reason? Because the weakness of chondrocytes, because sequelae of the cerebral plexi. So I had to use a pure hinge knee. And there's 5 years after revision. So the patient also have a geniculum. In this patient, they present with a global instability, but sometimes it can only present with a recurvatum without a global instability. Most because of a chondrocyte weakness or sometimes palsy. With this kind of instability, the operation duration with a very high failure rate. So sometimes we need use a hinge knee with extension stop. This is another patient. This male presented with the right knee recurvatum for more than 28 years. The patient can only extend the knee, cannot flex the knee because of the infection of the around the knee. I did the total knee arthroplasty for him. Use a TTO for the exposure, but after five years, the patient again get an unstable knee because of the weakness of the chondrocytes. Because of the chondrocytes, it's very thin, it's fibrostic, so can cause the failure of the plant. So sometimes we need a hinge knee with the extension stop is a good choice. So come to inclusion. Instability is one of the major causes of the total knee arthroplasty failure. It has various manifestations. Sticking to the principle of the total knee arthroplasty revision is the key for the treatment of the instability after total knee arthroplasty. Balance the flexion extension gaps, revise the full component in most of the time, use more constrained implant if needed. Thank you for your kind attention, and thank you again for being invited for this webinar.
Thank you, Professor. Very extensive presentation. Your cases are so stunning for us. I have a question, Dr. Zhou. When did you choose the poly exchange in the region unstable TKA?
Seldom, but I just saw one case because the for that case for the before operation I prepare for the total both femur and the tibia revision. But during the operation, I saw part of the PCL left that I resect the PCL and get a larger extension and flexion gap, but I can balance that. So I changed my mind to use only a thicker polyethylene insert.
Michael, do you do any poly exchange in revision?
Very good question. Our experience here in the United States, at least based on the reported series, polyethylene exchange alone has not been met with consistent success. Although with the more current designs, you have different options, as you know, with the bearing and the different levels of conformity. So that may become a little bit more of a little bit more utility as time goes on with the newer designs. And I think some of the data is because of the older designs and with less conformity at the, as Charlie pointed out, the femur and tibia articulation match in the range of motion in the kinematics. So we will see recently at the Knee Society meeting, there was an abstract from the Hospital for Special Surgery, and they look at operation for instability, poly exchange, and versus component revision. And when properly selected, and they have equal results in both groups. So again, just like the other two experts have already pointed out, the key is to one, determine that is the cause of the dissatisfaction and the functional limitation in that particular patient is instability. Then try to figure out what is their instability as they so detailed with regards to extension, flexion, or combined, and then figure out why you would have extension or flexion, and then see if you can balance it at the time of surgery. With poly exchange, generally, you can only affect both gaps equally. And sometimes if you accept extension being tight and the flexion may be slightly loose, depending on whether you have the post design and the cam post engagement, hopefully you can keep the flexion under control. But most situations, if the flexion gap is looser than the extension gap, then you have to decide how much lack of full extension would you accept when you upsize the insert, you know, like from 10 to a 12 or 14, then you have 5 to 10 degrees lack of extension, whether you will be willing to accept that or not. And generally, revising the tibial component alone seems to me to be about the same as changing poly. So most one component revision would involve the femoral side, whether it be alignment, upsizing, or not. Generally, it's like the two experts pointed out, is upsizing, unless the flexion gap instability is contributed by the slope on the tibia side. So you have a trapezoidal shape in the sagittal plane and contributing to flexion gap instability, then revising the tibia may be what's indicated.
Good point. Charlie?
Yeah, so I think Michael did a wonderful explanation of how the sequential steps. I have the same algorithm. I think to Michael's point, and Professor Zhou actually presented that the classic paper was out of Tom Fearing's group in Ortho Carolina, doing just a polyethylene exchange. The success rate about 60%. So I would just add that, you know, as I'm sure everybody is familiar with the diagram with the 9 boxes, right? We try to get the perfect flexion extension. And so I think to Michael's point is we want to identify whether if it's a symmetrical instability, asymmetrical instability, right, in the other 2 boxes, and how do you correct it, right? How do we get to the center box of equal? And I think with all of the examples that Professor Zhou presented, those are very challenging cases. I think that's what I always go back to, is that tic-tac-toe box, of 9, right? Of how many components to change. So
Yes.
that was those were very tough cases. Very tough cases.
Yes. Charlie, which situation you will choose the hinge in revision for unstable TKA?
Excellent question. So, and I think Professor Zhou presented in his case, I will always go from least constraint to the most constraint, because I think the more constraint you put on it, and the data has been pretty clear with a linked prosthesis, the survivorship is just not as great, right? And I think Professor Zhou showed 3 cases of failed linked prosthesis, right? So I think over time, those will fail, especially if you do it in a younger patient, right? So my indication for a linked prosthesis, if I truly cannot set an extension and a flexion gap. For example, like he showed, he put a 14 millimeter in extension, but in flexion, he put a 20 and still very matched. So 6 millimeters and beyond, he still can't match it. So those you have to link it. Patient with neuromuscular disorder, right? Significant recurvatum, people with cerebral palsy, with polio, those patients will probably be best served with a constrained device construct. So, or if they truly have an completely incompetent collateral ligament, either medial or lateral or both, those patients are probably best served with a linked hinge prosthetic construct. So those will probably be my 3 major indications for link. But I do like what Professor Zhou did in a lot of his. He used a mobile bearing semi-constrained, because if you are going to use constrained, you want to make sure you have another advantage of decreasing the stress in the construct. Although I did see he used one fixed bearing TC3 on one of his examples. So one of them. But the rest of them were all mobile bearing, which I think has this inherent advantages in a revision setting.
Yes. Agree. Okay. Let's go to the last section. That will be Professor Michael Hu's turn. Michael will tell us articulation TKA. This is about the prosthesis design to prevent the unstable TKA. I think it's very important for us. Thank you, Michael.
Well, thank you, Professor Hu. Let me share the screen. How come I have the same problem as we did the test before? Hold on. Well, thank you, Professor Hu, and it has been a great discussion and all the other presentations up to this point for this webinar. And for my part of the presentation for this program, and is on articulation constraint, it's not so much how to favor one versus the other, as some of the discussion has already taken place to this point in some detailed discussion about instability, but rather to just share with the audience some very basic understandings of the different types of the articulation available in total knee replacement. And I want to give appreciation to Antonia Chen, who's also well-known international surgeon, and she works in Boston at the Brigham and Women's Hospital, and she helped educate me greatly about some of these choices. And these are my disclosures, none of which has any conflict with today's presentation. And we're going to go over cruciate retaining, posterior stabilizer, posterior substituting, and the newer ultracongruent, which is not really new, or the cruciate stabilized. So either is UC or CS, depending on which letters you want to choose, a little bit on the knee kinematics, as well as the clinical results of a different bearing. And patient selection, as others have already said, including our chairperson moderator's presentation slides. And at the introduction, patient selection has evolved over the past 50 years since total knee replacement was introduced into clinical practice in the early 1970s. The patient demands today are different, and satisfaction with pain relief is only in 70 to 86% of the patients, as well as similar numbers for activity and function. And in most reported series, at least the older ones, the newer ones remain to be fully assessed. I got to give it time. And some of the complaints from the patient-directed outcome instruments, and including the Knee Society scores, Oxford score, WOMAC, and UCLA activity scale, and all that, is difficulty with daily activities, range of motion, stairs, as was pointed out by both presenters earlier, and a sense of stability. But overall, it just does not feel natural. We all recognize that in the knee replacement, at least in North America, in the United States population, as well as my personal practice of over 30 years now, after finishing training, maybe around 10 to 15% of the patients just don't feel right, in contrast to maybe 1 in 1,000 or several hundred among the hip replacement population. So looking at the articulation available on the market in today's market, and there are basically two broad types. One is a post, a design with a post, and the other one is designed without the post. And the post designs including the PS, and some companies offer the PS Plus or the constrained PS, CPS, and then as some of these revision cases so well illustrated in the complex cases is the ML constrained, the CCK type, or another word that you will read in the literature and in here in presentations, the varus and valgus constraint, or the VVC type. And the postless design is the classic CR, and the currently sort of resurgence of the ultra congruent or the CS constraint, Cruciate stabilized, or Charlie used the anterior stabilized. It is basically a ramped type of articulation, the medial pivot and the bicruciate. Which at least in North America has not gained a lot of traction since its initial popularity a few years back. And the American Joint Registry started pretty late on the world stage compared to other registries, but it has reached almost 10 years here in the United States. And looking at the data available from that registry, and PS knees are used in about 50% of those enter into the registry, CR knees in 40%, and 10% for other bearing options. Now, with regards to mobile versus fixed bearing, mobile bearing is a small amount, less than 10%. And majority fixed bearing, and the use of highly cross-linked polyethylene as the bearing material. Some newer ones even include the antioxidant highly cross-linked polyethylene is over 80% of the knees. And in North America, of course, patella resurfacing is in more than 80% of the data sets in the registry. As just to give you a look at what's happening in the United States. There is, however, no evidence to my awareness over the years which design is superior, whether it be by implant design or by the bearing choices. And with regards to patient-reported pain relief, function, or durability in wear and fixation loosening. However, going into the future and the debate with kinematic versus mechanical alignment, in particular with the different type of implant designs for each type of surgical technique, coupled with the newer technologies such as navigation, robotics, and digital balancers and whatnot, the word balance and extension, flexion, mid-flexion have been already used throughout the seminar up to this point. The key question to be answered with longer term follow-up going forward from today is whether from the patient's perspective, there will be any measurable separation among the different concepts, designs, and techniques. Perhaps, at least some people will argue, our measurement instruments in patient satisfaction and function, however sophisticated already compared to 50 years ago when this first started, remain not sensitive enough to pick out the difference. So looking at the CR advantages, the argument is to avoid the PS problems such as post-wear and breakage. And some of the case examples earlier in this seminar, we had already seen examples of clinical cases, clunk, condylar fracture from the box cut, and there are just some of the arguments. And also the people that favor CR articulation say preservation of important central stabilizing ligament structure, the PCL is important, and it also provides better proprioception. Therefore, the patient may feel more, quote, natural. In contrast to without the PCL. And the PCL, if it is functioning and balanced properly, will offer resistance to subluxation forces, as well as some varus and valgus stability. And transfer stress to the PCL, thus reduction in wear and fixation loosening in the long term. Additionally, it conserves the bone resection. The box resection is the obvious point. It's more consistent joint line preservation because in the PS knees, generally, when you cut the posterior cruciate ligament, at least in biomechanical testing, modeling, finite element, the flexion gap would jump 2 to 4 millimeters. And this has been recently within the last 12 months, how shall we say, it was confirmed with robotics and navigation from the London group, Ferris Hadas group, that indeed with PCL resection, the flexion gap does increase. And so most times in surgery, in order to balance the extension gap to the flexion gap, surgeons tend to resect a little bit more distal femur to chase the flexion gap with the extension gap. So in theory, it will raise the joint line. And there's unsettled debate with regards to whether stair climbing is easier or more effective with CR knees compared to PS knees, and also whether the patient will report that it feels more normal. So using posterior stabilized articulation in total knees, and the argument for the advantage is deformity correction without the need to balance or recess the PCL tension, and the gap balance is easier. And the thought of that simply because you have a post and cam with a box mechanism and it increases the ML stability, that it is not true, because at least my understanding and in my personal practice over the years, PS knees versus CR knees, if you balance it correctly, they should not make any difference. And the more conforming polyethylene surface, as Charlie began the seminar, is saying conformity in theory would decrease polyethylene wear. And in some people, they also argue increased conformity may improve the stability as well, especially throughout the arc of the range of motion. And other arguments include more reliable rollback of the femur on the tibia when the knee goes into flexion. And there's less range of axial rotation and condylar translation, more predictable kinematics. I will show some data in meta-analysis comparing CR versus PS knees with regards to range of motion difference, and then the potential benefit of avoiding late posterior instability, as some of the case examples in the other two presenters' presentations already show, both in osteoarthritis and in the inflammatory arthropathy patients. So the resurgence of the ultracongruent or the CS, as one can see in this slide in the American Joint Registry data, over the years, and these different color bars, and it has continued to increase, and then it plateaued in the last 3 years or so, but still it is increasing, as this arrow will show. And a lot of surgeons doing the CR knees will choose to use the ultracongruent to give, certainly in the sagittal plane, anterior posterior stability, as I will show you some data in the current design. And it does offer intraoperative flexibility between conserving PCL or sacrifice the PCL. It does avoid the box cut because you use the CR femoral component. And it also allows for gradual release of the PCL to optimize balance and the kinematics in some tough knee clinical cases. With regards to knee kinematics, in a normal knee with all intact meniscus and then no arthritis, as well as functioning ACL, PCL, the collaterals and secondary dynamic stabilizers like the muscles, capsule, and all that. In flexion, there is a posterior sliding of the lateral femoral condyle while pivoting around the medial compartment, as we all know. And this is done in using various methodologies, including what Charlie has said about his senior partner's legacy fluoroscopy, dynamic fluoroscopy. And in patients after a knee replacement, during early knee flexion, and that's argued whether between start to flex up to 60 degrees or thereabouts, but in the mid flexion range, the body weight pushes the femur forward. So there is this paradoxical anterior translation of the femur on the tibia until the PCL comes into play or until the cam and post engages in the PS knees or in a pegged design in a knee replacement. And so this abnormal anterior sliding of the femoral component on the tibia is different from the natural rollback, as we mentioned before. So whether this contributes to the decreased mid-flexion conformity and stability or not, different people have different opinions. And our moderator, as well as in the discussion, have mentioned about the femoral design. There are two basic principles on the market. One is the multi-radius or the J curve. The center of rotation shifts posteriorly with flexion, and the radius shortens with more flexion, and this can lead to potential mid-flexion ligament instability. That's what some people have argued, and Charlie said that the other design, the single radius, tend to favor in the CR knees, perhaps does not make much difference in the PS knee, in particular, depending on the cam post engagement when this paradoxical anterior versus rollback occurs. And in the single radius is a fixed axis for flexion and extension, and it reduces ligament tension alteration, at least in theory, and it may reduce forward sliding of the femur. That's why the proponents argue that it might help reduce the mid-flexion instability clinical entity. But there's no conclusive evidence that it does. Now, with regards to constraint, and all the presenters as well as the audience think about AP or the coronal plane, the sagittal plane or the ML in the coronal plane, but there's also a rotational component to it, because rotation is important for optimal knee kinematics, also relates to wear and knee stability, and in particular with patella tracking as well, and also the patient function and how the patient feels. So when looking at the kinematics after a knee replacement, the CR knees acts like an ACL deficient knee. There's the paradoxical femoral anterior translation. Generally, it begins at 40 to 60 degrees. You can see that at least in fluoroscopy, but it does not occur in all CR knees, but it does have been documented in over 3/4 of the knees. With regards to PS, there is less anterior femoral translation, in particular, depending on the cam and post engagement at what degree. And it is also different for fixed and versus mobile bearing PS in fluoroscopic data. And how about the ultracongruent of the CS? It acts more like PS, and the axial rotation tend to be closer to the normal knee. Controversies remain, and which type will offer you more range motion. However, if flexion is the focus, regardless of the articulation, higher flexion requires more posterior contact point between the condyle and the tibia, and everyone also would agree that you need more condylar offset to gain more flexion. That's why in the high flex knees, that were introduced into the market over 3 decades ago, there's always a thicker posterior condyle in order to achieve that for the posterior condylar offset. So here's what I have mentioned, some meta-analysis data from the, this decade anyways, after 2010. And there's clearly no difference between CR and PS knees with regards to the knee score, the pain level, function, mechanical, overall axial alignment or complications. And one consistent finding, however, is the PS group will generally have greater flexion and range of motion, as you see in the right-hand side, the 2 forest plot. And then the aggregate average favors PS in the range of motion as well as in flexion. And how about with the CS versus the PS? And this is just one example study that I chose to include for the presentation today in a prospective randomized trial, minimum 2 years on average, almost 4 years. CS 55 knees, PS 56 knees. The PS took longer operating time, perhaps is the box cut, but there was no difference in clinical radiograph as you see in these p-values in this table, cut and paste from that paper with regards to knee score, range of motion, and then mean alignment at the bottom. So increased conformity does not necessarily mean that increased stability. And the other experts have already mentioned coronal and sagittal plane. The CR versus PS, at least to my reading and my own personal clinical experience, is essentially no difference in stability if the knee is balanced and the component position is not in excessive varus valgus within, perhaps I'm so old that I still believe in the mechanical alignment, the ±3 degrees in the coronal plane. And there's no question the CS or the ultracongruent, as Charlie mentioned, is the anterior stabilized. And so that concept does offer increased sagittal stability, AP translation. And now the interesting question is on the VVC or the CCK varus valgus or ML constraint, whether it does offer more coronal stability or not. It does give everyone the feeling that when we examine the patient intraoperatively, there's no question that you have more ML stability, at least a surgeon will believe so. There's no question, at least in my mind and in the mechanical testing, there's greater jump distance for flexion gap stability problems because the higher post. However, as others have already spoken of in our very comprehensive discussion just prior to my presentation, if there's incompetent or absent MCL and in other neuromuscular conditions and just dynamic imbalance, and none of this will work, and a hinge device is probably the only solution. So in preparation for this preparation, I did, for this presentation, I did take some data from 2 implant systems that were introduced into North America practice in the last 10 years. One is a Zimmer Persona, and this is a table summarizing their cruciate retaining, ultracongruent, PS, and they call constrained PS or PS plus. All right, let's go on to the internal external rotation, as I may mention. So the other knees offer ±15 degrees, the other CR, UC, and PS. But in the CPS, the higher post for the PS, and it reduces internal external rotation. And the varus and valgus constraint for the CR, UC, and the ultracongruent or CS, there is no added varus and valgus constraint. But for the CPS, there's only 1.5 degrees. But in the sagittal plane, anterior subluxation resistance, in contrast to the CR knee, the ultracongruent has the most. Of course, in the post design, both PS and the CPS in flexion, the cam and post engagement, unless your flexion gap is so unstable and jump the post, as Professor Joe showed one of his cases that jumped the post right after surgery because of flexion gap instability. It should not have any problems. And these are the different pegged designs in that system: PS, CPS, and CCK. So if we just look at the CPS versus the CCK in varus and valgus, here's the varus and valgus constraint is plus minus 1.5 degrees, and the CCK in this system is only plus minus 0.5 degrees. And then with regards to the internal external rotation, 5.5 degrees versus 1.0 degrees. So it could be the box design in this particular system. And the other implant system is the DePuy or the Johnson & Johnson 2 system that have been introduced into clinical practice in the last 10 years here in the United States. Here is a table from the manufacturer comparing their tibial femoral sagittal plane conformity that was introduced today at the beginning from Charlie Young's presentation. So this is the older Zimmer next gen CR. These are all CR knees. Vanguard Biomed, Genesis 2 Smith & Nephew, Triathlon from Stryker, and the Attune. You can see at different degrees of 0 to 120 degrees, and it has better conformity in the sagittal plane. Then within the system itself, there's difference between the CR and the PS at the different degree of flexion. If you just look at the bottom of the table that I cut and paste into this slide from their technique guide, and with the CR is 0.88 ratio, and then to 90 degrees at 0.67 for the CS knee, for the CR knees, but in the PS knees, that ratio decreases as flexion increases. So although, even within the same femoral component radius design, depending on what type of articulation you choose, there are different conformity changes throughout the arc of motion. So in summary, as others have emphasized in their summary slides, the surgeon must optimize balance during surgery. And in most surgeons, they use a combined bone resection and gap balancing technique. And as I do in my practice, and the argument continues with mechanical alignment versus kinematic alignment, as I had already mentioned and disclosed, because I've been in practice for 3 decades or longer, I have remained more in the belief with the mechanical alignment. Articulation alone generally may not eliminate instability. It may or may not improve instability, at least from the surgeon's perspective. Most surgeons believe if you go from a CR to a PS to a PS plus to a VVC or ML constraint such as the CCK, TS, TC3, you do increase stability, perhaps more so in the flexion gap than in the extension gap. And now the question, as I have introduced on several occasions throughout this presentation, is newer technology with navigation, robotics, patient-specific guides, and digital balancers, or a combination of all of this will change and reduce the instability problem that we experience clinically at this point. So again, I want to thank you. I want to thank Asia as a society and offer me the opportunity to participate in this seminar, and our chairperson, moderator, Professor He, as well as I have learned the opportunity for me to have learned from the other speakers, the experts, and on this particular subject matter. Thank you.
Thank you. Thank you, Professor Michael Hu. Giving us the whole knowledge of articulation in total knee replacement. I think it's very useful for us to choose the right prosthesis for patients. Let's discuss with this topic. I have a question, Michael Hu. Sometimes you use CRD or PSD, right?
In my practice, it's almost always PS. But we do use some CS. We use some cruciate retaining knees for training surgeons, because right now I used to have partners, but they retired. They prefer the CR articulation, and now the practicing surgeons within our residency program, they all use PS. So I do use maybe around 10 to 15% of the knees we will use a cruciate retaining. And then in a cruciate retaining case, we sometimes use the CR articulation, the bearing, or we sometimes use the ultra congruent, just to show the residents what the differences are. Yeah.
Okay, very good. Is there any difference in balance gaps between CRD or PSD? Do you have any experience for that?
A very good question, because I was trained, brought up, and worked and practiced with the PS knee. And it's natural for me to sort of think of it as two square boxes, you know, and then with the laminar spreaders. And we do preserve the PCL when we do use the CR femoral component. And I have generally use the cruciate retaining knee in very low degree of deformity and flexion contractures, probably 10 degree each, and only in varus knees. I have not tried with my limited skill set using CR articulation in valgus alignment knees. I just don't think I can make it work very well. Like the likes like Ken Krakow and others in the past, they could make CR knee work in just about any deformity, any clinical situation. Leo Whiteside, for example, I cannot. So we have only used CR knees in very low degree of deformity or bone loss, and always in the varus knees, not in the valgus alignment. So the balance is actually minimal effort, I would say. Okay, it's just almost like a kinematic. You just do bone resection, and then because of the lack of deformity, bone erosion, or a great degree of malalignment, you just sort of do a resurfacing. Yeah.
Okay. My next question maybe go to three professors. We know the balance is most depend on the individual experience by now. You prefer totally balanced in extension and flexion gap, or medial lateral totally balanced, or maybe some little bit tight in medial side than compared to the lateral side, or little bit tight in extension gap compared to the flexion gap, or totally balanced. First, I think I want to ask a question to Talia.
Okay, great. So great question. So I think the fundamental principle is to obviously try to achieve a balanced, equal flexion as well as extension gap. If I had to choose between tighter medially or laterally, I'd rather be 1 to 2 millimeter tighter medially than laterally, because a natural knee is slightly, a native knee is slightly lax in the lateral compartment. So, but my goal is obviously to try to get equal medial and lateral joint space. If I had to cheat between a tighter extension gap versus a tighter flexion gap, my tendency is to actually have a tighter flexion gap than extension gap. I have actually evolved my practice from a posterior stabilized knee surgeon. I do about 90% cruciate retaining or ultra congruent or anterior stabilized total knees now. And I've been doing that for about three years now. So that would be how I would choose. So, number one, if we can achieve it, equal. If I can't achieve it, I would prefer tighter in the medial side in extension. If I can't achieve equal extension and flexion, I'd rather pick just a slightly tighter flexion and let the extension be just 1 to 2 millimeter looser.
Okay, very good. Dr. Zhou,
Yeah,
what do you
good question.
prefer?
Because just like Charlie said, it depends on what kind of procedure you use. Because I'm a, PS guy, so I think it's art, not a technique. Because
You're artist.
also depends on what you want. You want to have a very stable knee, or you want to balance the stable and mobile to the range of motion. So I prefer high flexion. So for the extension, I prefer that the medial side can open 1 to 2 millimeters, and the lateral can 3 or 2 or 3 millimeter. That means 1 to 2 millimeters larger than the medial side. And for the flexion gap, I think the flexion gap can 1 to 2 millimeters larger than the extension gap. So that's my philosophy. So in that case, not only I can get a stable knee, but also I can get a good function of the knee.
Professor Zhou, you show some case with many cases, your case with deep scar after surgery. I think your case maybe is a little bit loose, flexion gap, is right?
No. First, I have a stable knee.
Oh, okay. I see.
During the presentation, you can say I trust the extension and the flexion gap many times. So I can get a stable knee, and then I can get a high flexion.
I get it. Michael, what's your opinion?
Well, perhaps he is similar to Charlie here in the United States. I would, if I had to choose, probably a little tighter on the medial side in extension in regards to your question versus lateral, and choosing between extension and flexion, I would tend to favor tighter in flexion and extension. But that reason for the extension, perhaps I was trained by earlier surgeons. My residency was in the mid 1980s. And I started to practice in 1990. We had implant designs that were non-modular and had about 5 sizes of femur, 5 sizes of tibia, and 5 thicknesses, and there's no right or left femur and all these things. So you didn't really have a lot of choices. And somehow the emphasis of trying to leave the extension a little looser so they don't end up with flexion contracture, which will limit their gait and function post-surgery, just always stay with me. So in the operating room, if I had to choose whether to leave the extension a little looser, I will leave the extension looser than in flexion if using the same polyethylene insert thickness. That's just my natural tendency over the years.
Yeah. Okay. I see. Our goal is to get the equal balance, the medial and lateral and the extension and the flexion get equal is my first goal. But if we can get that, maybe a little bit tight in medial and a little bit tight in flexion gap, I think we all agree with that. Now I will have more size prosthesis, so I think I maybe easy to get my first goals. I think that is make it's our advantage by now. Very good discussion today. We have many issues is waiting for discuss, but it's time out. Thank you for again for your support and the help. I think it is very useful for joint surgery to include the practice from this program. Thank you again. Looking forward, we meet again. But online, I think I look forward with each other face to face. Where can Professor Michael Hu and Professor Chen Yang come to China again? Welcome to Shanghai.
Welcome to Beijing.
Thank you.
Of course,
Thank
two of my favorite cities. I'll
Okay.
definitely do it. Be perfect.
谢谢主
Thank
任
you.
呢。
谢谢，
Yeah,
非常
appreciate it.
感谢，非常感谢。